Welcome to the Dr. Izzy's Medical Podcast channel.
Hyperaldosteronism. Hyperaldosteronism is a medical condition wherein too much aldosterone is produced by the adrenal glands, which can lead to lowered levels of potassium in the blood. It's called hypokalemia, and increased hydrogen ion excretion. This cause of mineralocorticoid excess is primary hyperaldosteronism, reflecting excess production of aldosterone by adrenal zona glomerulosa. Bilateral micronodular hyperplasia is more common than unilateral adrenal adenoma. Signs and symptoms. It can be asymptomatic, but these symptoms may be present. Fatigue, headache, high blood pressure, hypokalemia, hypernatremia, hypomagnesemia, intermittent or temporary paralysis, muscle spasms, muscle weakness, numbness, polyuria, polydipsia, tingling, metabolic alkalosis, nocturia, blurry vision, dizziness and vertigo. Causes of hyperaldosteronism. The causes of primary hyperaldosteronism are adrenal hyperplasia and adrenal adenoma. These cause hyperplasia of aldosterone-producing cells of the adrenal cortex, resulting in primary hyperaldosteronism. The causes of secondary hyperaldosteronism are accessory renal veins, fibromucular dysplasia, reninoma, renal tubular acidosis, nutcracker syndrome, ectopic tumors, massive ascites, left ventricular failure, and cor pulmonale. These act either by decreasing circulating fluid volume or by decreasing cardiac output, with resulting increase in renin release leading to secondary hyperaldosteronism. Secondary hyperaldosteronism can also be caused by proximal renal tubular acidosis. Secondary hyperaldosteronism can also be a symptom of genetic conditions Bartter syndrome and Gittleman syndrome. Diagnosis of hyperaldosteronism. When taking a blood test, the aldosterone to renin ratio is abnormally increased in primary hyperaldosteronism, and decreased or normal but with high renin in secondary hyperaldosteronism. Types of hyperaldosteronism. In endocrinology, the terms primary and secondary are used to describe the abnormality in relation to the defect, the tumor's location. It also refers to causes that are genetic or due to another condition or influence. First type, primary aldosteronism. Primary aldosteronism was previously thought to be most commonly caused by an adrenal adenoma, termed Conn syndrome. However, recent studies have shown that bilateral idiopathic adrenal hyperplasia is the cause in up to 70% of cases. Differentiating between the two is important, as this determines treatment. Also, see congenital adrenal hyperplasia. Adrenal carcinoma is an extremely rare cause of primary hyperaldosteronism. Features are hypertension, hypokalemia, alkalosis. Investigations. High serum aldosterone, low serum renin, high-resolution CT abdomen. Management of primary aldosteronism, solution for adrenal adenoma is surgery treatment. Bilateral adrenocortical hyperplasia, aldosterone antagonist, spironolactone. Secondary hyperaldosteronism is due to overactivity of the renin-angiotensin-aldosterone system. Secondary refers to an abnormality that indirectly results in pathology through a predictable physiologic pathway. A renin-producing tumor leads to increased aldosterone, as the body's aldosterone production is normally regulated by renin levels. One cause is a juxtaglomerular cell tumor. Another is renal artery stenosis, in which the reduced blood supply across the juxtaglomerular apparatus stimulates the production of renin. Likewise, fibromuscular dysplasia may cause stenosis of the renal artery, and therefore secondary hyperaldosteronism. Other causes can come from the tubules. Low reabsorption of sodium will lead to hypovolemia and hypotension, which will activate the renin-angiotensin system. Secondary hyperaldosteronism can also be caused by excessive ingestion of licorice or other members of the Glycyrrhiza genus of plants that contain the triterpenoid saponin glycoside known as glycyrrhizin. Licorice and closely related plants are perennial shrubs, the roots of which are used in medicine as well as making candies and in cooking other desserts because of the sweet taste. Through inhibition of 11-beta-hydroxysteroid dehydrogenase type 2, glycyrrhizin allows cortisol to activate mineralocorticoid receptors in the kidney. This severely potentiates mineralocorticoid receptor-mediated renal sodium reabsorption, due to much higher circulating concentrations of cortisol compared to aldosterone. This, in turn, expands the extracellular volume, increases total peripheral resistance and increases arterial blood pressure. The condition is termed pseudohyperaldosteronism. Secondary hyperaldosterone can also be caused by a genetic mutation in the kidneys which causes sodium and potassium wasting. These conditions can be referred to syndromes such as Bartter syndrome and Gittleman syndrome. Treatment of secondary hyperaldosterone. Treatment includes removing the causative agent, a high potassium, low sodium diet and high sodium diet, spironolactone and eplerenone, potassium-sparing diuretics that act as aldosterone antagonists, and surgery, depending on the cause. Secondary hyperaldosterone may also be treated with COX-2 inhibitors, which cause water retention, sodium retention and potassium retention, as well as raising blood pressure. Bartter and Gittleman syndrome tend to cause low blood pressure in significant populations, and treatment with blood pressure medications tend to lower the blood pressure even more. Hypoaldosteronism. Hypoaldosteronism is an endocrinological disorder characterized by decreased levels of the hormone aldosterone. Similarly, isolated hypoaldosteronism is the condition of having lowered aldosterone without corresponding changes in cortisol. Causes. There are several causes for this condition, including adrenal insufficiency, congenital adrenal hyperplasia, and some medications such as certain diuretics, NSAIDs, and ACE inhibitors. And other causes are: primary aldosterone deficiency, primary adrenal insufficiency, congenital adrenal hyperplasia, aldosterone synthase deficiency, secondary aldosterone deficiency, secondary adrenal insufficiency, diseases of the pituitary or hypothalamus, hyporeninemic hypoaldosteronism, renal dysfunction, most commonly diabetic nephropathy, NSAIDs, cyclosporin. Mechanism of hypoaldosteronism. Hypoaldosteronism may result in high blood potassium and is the cause of type 4 renal tubular acidosis, sometimes referred to as hyperkalemic RTA or tubular hyperkalemia. However, the acidosis, if present, is often mild. It can also cause urinary sodium wasting, leading to volume depletion and hypotension. When adrenal insufficiency develops rapidly, the amount of sodium ion lost from the extracellular fluid exceeds the amount excreted in the urine, indicating that sodium ion also must be entering cells. When the posterior pituitary is intact, salt loss exceeds water loss and the plasma sodium ion falls. However, the plasma volume also is reduced, resulting in hypotension, circulatory insufficiency, and, eventually, fetal shock. These changes can be prevented to a degree by increasing the dietary sodium chloride intake. Diagnosis. Patients with a suspected diagnosis of hypoaldosteronism are often screened with simple blood tests. Potassium levels, plasma aldosterone concentration, and plasma renin activity are the three most useful in the first instance. Low aldosterone levels in the presence of high renin activity, often with low sodium, high potassium, is associated with primary hypoaldosteronism. Secondary hypoaldosteronism may be suspected if renin activity is low with low aldosterone concentrations. The plasma aldosterone to renin ratio is calculated to determine if levels are sufficiently deranged to consider a diagnosis of hypoaldosteronism. If screening test is suggestive, a more definitive diagnosis is made by performing a saline suppression test, ambulatory salt loading test, or fludrocortisone suppression test. Imaging to detect an adrenocortical adenoma may also be considered. Treatment. Aldosterone deficiency should be treated with a mineralocorticoid, as well as possibly a glucocorticoid for cortisol deficiency if present. Hyporeninemic hypoaldosteronism is amenable to fludrocortisone treatment, but the accompanying hypertension and edema can prove a problem in these patients, so often a diuretic is used to control the hyperkalemia.
Thank you for listening Dr. Izzy's Medical Podcast Series. If you want to support this project, please subscribe the channel and like this video. Thank you.